Good afternoon. It's a great pleasure to come to you today because it's a real thrill of mine to be able to welcome Christopher Pannucci to the stage. And Christopher Pannucci and I have known one another since he was a resident, and he had a very early and fervent interest in venous thromboembolism and worked in the University of Michigan with them, helping to develop the original studies and in 2012, the Chest Consensus Conference acknowledged the Caprini Score for the first time as something that was important as a way to risk assess patients. Up to that time, they had been skeptical about individual risk assessment. And one of the things that put it over the top was Chris also had worked with a VTE group of 5 university centers that enrolled 1,125 patients we were having inpatient plastic surgery and had a Caprini score of over 3. And he showed, which was a stunning result, that almost 11% of them at 60 days had a clinical clot. And so this started the ball rolling. He's had a very illustrious career since that time, with an intense interest in individually quantifying risk assessment. And one of the real things that has been, to me, very exciting is he hasn't been sitting there patting me on the back all this time. He's been pointing out the various differences and what's wrong with the score and how it needs to be improved and a whole bunch of things. And of course, that's what we're both after. We're not after individual accolades. We're after to improve patient care and to lower the overall risk of venous thromboembolism. Now, currently, he has a plastic surgery practice in the Northwest in Spokane, Washington. He specializes in microsurgical procedures, breast reconstruction, and aesthetic surgery. And he's an international speaker, and he's participated in at least 13 trials regarding risk assessment and over 130 publications around the world. So again, it's a real pleasure, Chris, to welcome you to the screen. And I know you have thought about this problem for a long time, and it's a fascinating discussion. I can't wait to hear you go.
Well, absolutely, and to be fair, there's lots of things, Joe, that you and I could probably spend a huge amount of time kicking around thoughts on. Specifically for today, you had asked me to comment on a recent paper that I had written, looking at risk stratification and risk level in the elective ambulatory plastic surgery population. I think that, this goes back. This is one of the first pictures that I have of you and I think this is from the American Venous Forum meeting almost 10 years ago now.
Right.
But even well before that, with solid mentorship of Tom Wakefield and Peter Henke and Ed Wilkins at the University of Michigan, I was thinking about risk for clots initially in plastic surgery patients using individualized risk stratification, but ultimately risk in surgical patients as a whole. For me, the article that you wanted to discuss today was recently published in Plastic and Reconstructive Surgery Global Open, looking at my own patients, a consecutive series of 100 patients presenting for breast augmentation, a heavily pre-screened and selected, generally young, fit, and active population, to say, what is the distribution of their Caprini scores? Do these patients have modifiable risk factors for clots? But also leveraging those data to better understand the overall aesthetics population. What kind of people are they from the perspective of clot risk? And to do a simulation study, a Monte Carlo simulation, to try to tease out, well, what should the distribution of risk levels of people who gets clots look like? Thinking about VTE and breast augmentation, it's interesting that when I bring this topic up, sometimes within plastic surgery, but certainly to other surgeons, a lot of people say, well, why bother? And the reason for the why bother question is this. This is a great study that I go back to a lot by Julian Winnicor and colleagues, looking at nearly 130,000 aesthetic surgery patients in a national cosmetic surgery insurance database called Cosmetisure. And in that nearly 130,000 patient population, there were 41,000, almost 42,000 patients who had breast augmentation. And this is an insurance database. And the way that it works is that surgeons enroll all of their patients into this, and if their patient has a complication, it is a way to have those complications, which generally are not covered by insurance, to have those costs covered for the patients. So people are actually incentivized to report complications to this database, so that the data should be pretty good. In this database, they showed that 30-day risk for blood clots in the legs or lungs after breast augmentation was on the order of 1 in 10,000, or 0.01%. So again, this is very different than the inpatient population for any surgical population, plastic surgery included, because the baseline risk of these patients is so incredibly low. So does this matter? Why bother, right? Get back to that question. Well, I thought about this number a lot and how to put it into context. And I thought about it this way, that I have had a driver's license for, these data are a little bit older, now 27 or 28 years. And let's say that I average 2 trips in the car a day. In 27, 28 years of driving, I have had 2 accidents. And if I rough out the numbers, my risk of getting in a car accident when driving is around 0.01%. And yet there is a mandate from the states and from the government that people wear a seatbelt, even though the risk of getting in that car accident is incredibly low. And why is that? Well, it's because the risk of putting on a seatbelt is pretty low. The burden of putting on a seatbelt is pretty low, but it has the potential to prevent a catastrophic problem. So for me in my own practice, I'm always thinking about baseline clot risk and what I can do to modify risk for clots, even if it's low. And some of the paradigms that I've talked about at meetings, and certainly, Joe, that you and I have talked about in the past, may not apply. And as we talk about risk modification, sometimes I give people the option that says, listen, your baseline risk is 0.01%, 1 in 10,000. If we take away your oral contraceptives, we can further decrease that risk. But it's already a very low risk. So I'm going to let you and I make that choice together. So with that as background, this is one of those questions that has been kicking around in my brain for 5 or 10 years. And this paper, which was published in the Aesthetic Journal in 2018, I saw data for this paper at a meeting about a year before. So for 5 years, I've been trying to figure out, how do I explain these data? These are data from Jeff Keys using the international-based quality assurance program database, which is a database looking at ambulatory surgery centers and complication risk. And this was a specific study that looked at, I think it was 240 patients with abdominoplasty who also had blood clots. So this is not looking at all abdominoplasty patients. It is only looking at the 240 that had a blood clot after their operation. And what was really interesting was when they looked at what was the Caprini score distribution in these patients, they showed that the majority of patients who had a blood clot after an abdominoplasty had a low Caprini score. And this was really interesting because after this, many people, including the authors, suggested that, well, maybe Caprini risk stratification doesn't work for the lower risk aesthetic surgery population, because clearly based on these data, if everyone who has a clot has a low risk score, that doesn't really make sense. Now, part of the problem with this study was that it didn't have a denominator, right? They were able to give us all the characteristic of the numerator population, the 240 people who had clots, but they didn't actually have data on the overall population. So that was the thing that I said, well, in my head, we need to improve that, because we need to know more about the overall population before we can make this discussion. So in my own practice, I did a consecutive series of 100 breast augmentation patients, not even people who I chose to operate on, but just people that come in the door for a consultation, to try to get a better idea in a pre-screened aesthetic surgery population presenting for what is perceived to be a low-risk ambulatory surgery. What are their baseline risk characteristics? And this is what I found in 100 consecutive patients who saw me for breast augmentation. I realized actually that there was a mistake in this figure. There were actually 36 Caprini 0 to 2, because if you add these numbers up, they add up to 99. My apologies about that. But what this study shows is that, kind of as expected, the overall majority, or the overwhelming majority of breast augmentation patients, and by extension, probably cosmetic surgery patients as a whole, are at low risk for clots. When I did a face-to-face Caprini risk stratification, you see that most people had scores of 0 to 2 or 3 to 4. There was no one in my consecutive series that had a score of greater than 8, and there were 4 people, 4 out of 100, who had a score of 7 to 8. So this is really interesting because it helps to start shed some light onto that question of what are the baseline demographics, and we'll come back to that in a second. I also looked at opportunity for risk modification, right? So how many of those 100 people had any risk factor that we could improve upon? Some people, it might be that they lost multiple pregnancies, and at least to have the discussion, was this worked up? Are there additional data points that we can get? Some people would come in and they were taking oral contraceptives, and can I have them hold that oral contraceptive in advance to further decrease their risk? And what I found was that about 30% or so of people of the overall population did have a potentially modifiable risk factor. Now, it's interesting that in the higher risk inpatient population for surgery patients as a whole, we're always looking for opportunities to say, listen, we can make your risk better. And taking someone, for example, from an inpatient Caprini score of 9 to an inpatient Caprini score of 6 or 7 can make a big difference in their 60-day VTE risk. We know that from surgery as a whole and plastic surgery as well. But in the ambulatory population, the expected decrease in risk is a fraction of a percent. When your baseline risk, and this is the conversation I have with people in my office, when your baseline risk is 1 in 10,000, I say, listen, you can come off that oral contraceptive. It will decrease your risk from 1 in 10,000 to some slightly smaller percentage. And sometimes people appropriately say, well, what if I get pregnant? And so that is a very real consequence of that risk modification. And so for these very low risk people, I am just having a real-time conversation, surgeon and patient, to talk about the risk and benefit of further modifying an already low risk. Now, what's truly interesting about these data is that it's the first time that I'm aware of that we actually have baseline demographic information for a breast and body surgical population, saying that 4% of people are at higher risk on the Caprini scale. And so what I did was work with some of my colleagues at Stanford University to do a Monte Carlo simulation, creating fictitious populations. The first population that we tried was 96% Caprini 6 or less and 4% Caprini 7 or higher. We then modified that to be a 98 and 2% split. And we did this with the Monte Carlo simulation. I used inpatient data from plastic surgery. And again, you can argue whether inpatient data are directly relevant to this ambulatory low-risk population, but at least for inpatient plastic surgery data from the VTEP study that Joe mentioned before, I know that the risk for Caprini 7 and higher patients is 6-fold higher to have a clot at 60 days when you compare them to the lower group. So those were the population characteristics, that we had 96% of the population that was at a 6-fold lower risk of getting a clot. And when we ran 1 million simulations, it was really interesting to see what we found. If you focus on the right hand, in that hypothetical 98% Caprini 6 or less population, we were able to mirror the results of that Keys study almost exactly. And you can see that red bar is the 90% split from the Keys data. And with that hypothetical 98-2% split, we got to that 89% where you were expected to be lower risk. So this is really, really interesting. It helps us to sort of backfit what the baseline characteristics of the Keys population were for abdominoplasty, and also help to better understand how could it possibly be that most of the people who have clots are at lower risk. And at the end of the day, I'll go back to that slide in a minute, what we found is that for a very common population, when 96 to 98% of your population is at lower risk, even a very infrequent event in that higher number of people is going to add up to more overall events than in the higher risk group. So a very interesting study. First of all, we know that the aesthetic and ambulatory population is expected to be at a very low VTE risk. We know that only 4% or so of the population is going to be at that Caprini 7 to 8 or greater than 8 threshold, which most people now believe is at that higher level of risk. You do have to take that with a grain of salt because you're comparing it to inpatient data from plastic surgery. And I did show that about 1 patient in 3 had the opportunity for risk factor modification. Now, again, whether you should or need to be modifying risk when baseline risk is already 1 in 10,000 is up, in my opinion, for a conversation between surgeon and patient. And finally, I think that the presented data really helped to explain these data from Keys and colleagues, showing that a rare event in a common population as an aggregate is going to occur more frequently than a common event in a rare population. So really helping to better understand VTE in the aesthetic, ambulatory, and elective plastic surgery population. Really neat stuff. I know, Joe, that you have a lot of thoughts, and I would assume some questions on this, because this is a little bit outside of the mainstream, right? Everything that we've done, even going back to the original studies of Anita Ball and Tom Wakefield and you and Peter Henke from the University of Michigan, a lot of the work that's been done with individualized risk stratification and the Caprini score has been done in the higher risk inpatient population: abdominal and pelvic cancer surgery, vascular surgery, inpatient surgery. And so to take this to the realm of elective, aesthetic, and ambulatory is definitely different. And frankly, some of the results are not the same, and the paradigms are not the same as what we've seen in the inpatient population. I'm curious, as I stop sharing my screen, Joe, what are your thoughts?
Well, I think it's a fascinating study, and I go back to the corollary of using. We all use seatbelts, even though the chance of death is very low, but the chance of avoiding that uncommon catastrophe makes a big difference. And it's the same story with, you're operating on these ladies. A lot of these ladies are mommy makeovers. They've got children, they've got families, and even once in a very uncommon event may be a disaster for that family. And of course, that's what we're trying to get our arms around. And unfortunately, overall, although venous thromboembolism, fatal pulmonary emboli are the most common preventable cause of death after surgery, the rates are still going up. The latest data I have show that the rates are not going down. And so using all possible mechanisms to reverse that, I think, is important. And one of the key things here is that you're trying to suggest to people, just because you have a large body of low-risk surgical patients, don't forget about risk assessing them, because within that population, you'll find a few patients that are the bad apples in the barrel. And there's two things in my mind that I'm very frustrated about. And the first is that people don't ask the question about obstetrical complications. Multiple unplanned abortions, stillborns, growth retarded infants, placental insufficiency, severe preeclampsia, toxemia of pregnancy, because those particular clinical events may signal that the person's carrying a thrombophilia marker, an antiphospholipid antibody syndrome, lupus anticoagulant, beta-2 glycoprotein, and that may stay with them for life. And especially, of course, in these young women, if they have that, then all of a sudden they're at high risk to develop a venous thrombosis, especially if they have multiple of those defects within that category. And it mystifies me that, do you know of any other risk assessment in existence that looks at obstetrical misadventures? What do you think about that?
I don't, to answer your question. And I think to back up a little bit, it is really interesting, the role of risk stratification to find that that uncommonly high risk person in a generally low risk population. And again, just to reiterate from my perspective, it is interesting that in a lot of circumstances, we are saying, listen, we know that you're a very high risk population. You're a cancer patient. You're having inpatient intra-abdominal surgery. You're having a PICC line. And for those people, they rapidly ascend to that level where, we expect that a multimodal strategy of risk modification and also anticoagulation is potentially going to help them. But this population is very different in that their expected baseline risk for clots is so low. There are inpatient populations, and you know this, Joe, where your risk can be up to 10%, 1 in 10. We are talking orders of magnitude lower here, that, this is a 1 in 10,000 risk population. And so for them, while there is the opportunity to say, oh, you have modifiable risk factors, in my opinion, for those very low risk patients, it does come down to a conversation of saying, well, we can potentially take these risk factors away. It may provide you an aggregate benefit of a decrease of a fraction of a percent. but especially going back to contraceptives again in these young in these young women who might be in their 30s, it does have a potential downside. And I have left people on oral contraceptives through surgery because that was their preference. They said, I would rather avoid the risk of having an unplanned pregnancy as opposed to decreasing my already low risk by a fraction of a percent. So involving the patient in that discussion is definitely very relevant in my own practice.
Well, I think that's another point that I'd like to underscore that you made, which I think is extremely valuable. And if there was one of the good parts about the ASH 2019 surgical guidelines is they included a part about asking patient preference. And in this case, pregnancy can cause DVT much more commonly than
it's a great
being
point.
on the pill and having a breast augmentation. So I think that's a very important conversation, and that's where you have to get away from pure academic guidelines and clinical practice and put things into perspective along with the patient. Now, the next thing I wanted to talk about is family history of thrombosis. And I know in the risk scores that are approved that none of those risk scores, except for one, talk about family history. They all talk about thrombophilia. And that astonishes me. And I'm talking to you as another sort of, you're an internationally known now, younger authority on risk assessment. And we know if you take 100 patients and you do thrombophilia markers in 100 patients, you'll come up with about 3 or 4 positives. So that most of the patients that develop a thrombosis will not have a marker identifiable. Now, suppose that's a family member like your mother or your father or your brother or your sister. You need to ask if there's a family history, because to me, that's critical. And now when the Brits did this, the British have a risk assessment system. It's different than the Caprini score, but it's a very good system. And they also tied it to mandatory implementation or you don't get paid. And they had family history in it. And they envisioned that they saved 900 lives over a 2-year period from fatal pulmonary emboli because of people following this policy. So here's where I'm coming with all of this to you. You see one of these ladies, and let's say that it's not. The other thing that I've seen happen with a lot of these mommy makeovers, it's not just breast augmentation. It's liposuction, abdominoplasty, breast augmentation, sometimes the whole ball of wax. And sometimes that'll take quite a bit of time. Suppose you see one of those outpatients and and this is why I think it's important to ask them about their family history of thrombosis and their obstetrical misadventures. And let us say that they have either one of those. How do you recommend proceeding? Would you right away talk about that?
Well, I think it's important to talk with people, and to be fair, when we talk about standards, the last time that organized plastic surgery made a comment on this, there's the 2011 guidelines from the American Society of Plastic Surgeons, right, and then the 2016 guidelines from the American Association of Plastic Surgeons, and even as far back as 2011, when they had the results from that VTEP study, which was the 1,126 patient multi-center study that you mentioned earlier, the American Society of Plastic Surgeons definitely advocated for individualized risk stratification for the plastic surgery inpatient population, because that's the population for which we had excellent data. To be fair, those recommendations still said can consider completing a 2005 Caprini score or similar, solely because the score has never actually been validated in the ambulatory or outpatient population. And part of that is a question of sample size calculation. When we know that Winnicor study that I put up, the overall risk for clots in the ambulatory plastic surgery population is 0.1%, 1 in 1,000. So if you were to design an intervention and try to look for statistical significant difference of decreasing that 1 in 1,000 risk to 1 in 2,000, it requires huge numbers of patients, thousands and thousands of patients in either arm. And that is a study that is at the least very challenging to do, and at the most maybe almost impossible. And I say that as someone who's run the second largest randomized controlled trial ever done in plastic surgery. It took us at one institution 2.5 years to do a study that randomized 294 plastic surgery inpatients. So for me to look at randomizing thousands and thousands of elective surgery patients, that would be a daunting task for sure. So it's definitely a challenge to do the study
right.
well, and I think that that's really important to note.
So I understand all of that, and now I'm saying, as you have a 45-year-old lady, and that's going to have the triple mommy makeover, and her mother died of a fatal pulmonary embolus. Would you consider separating those procedures to lower the overall level of risk, knowing, for example, that if you did the breast by itself, there's an infinitesimally low incidence of thrombosis, and that would be much more safe from that lady than trying to do them all together? And under what circumstances would you give the outpatient prophylaxis?
So I think there's a lot of great questions in there, and these are things that I talk with about other plastic surgeons a lot. A lot of people will call me up and they will say, listen, I have the binary question for you of this is the patient scenario. This is what I'm doing. My binary question is, should I give them a blood thinner? Yes or no? And for me, I always back up. And, there's a great sort of conceptual guideline or flow sheet that I've published in the past that looks at opportunity to address, identify, and modify risk at different phases in the point of care. This is why, for me, I'm actually doing individualized risk stratification in my initial clinic visit, because if you are in the pre-op area and you find out, oh, there is this thing that could have been worked up, right, now you've given up that time and that opportunity, especially for a completely elective surgery where delaying a month or two is totally reasonable. For me, I'm looking at opportunities starting at that initial clinic visit, talking about family history, talking about personal history, talking about your reproductive history, and looking at opportunities. Is there anything else that should or needs to be worked up? And considering that in the context of what is your Caprini score, what is your baseline risk? You mentioned a good one about things to do in the operating room. And while it's not always possible, there are good data in plastic surgery that suggest avoiding a general anesthetic when possible. And again, realizing that not every operating room, not every anesthesia team has the ability to do surgeries under a non-general anesthetic. But things in the operating room is avoiding a general anesthetic if possible. That's known to be correlated with a decreased risk for postoperative clots. Using sequential compression devices, especially when you're under a general anesthetic and you are paralyzing people and taking away that calf muscle pump. Splitting up the procedures is a great one. And again, I'll push back a little bit on this one because this is completely elective surgery. And in that sense, it is ideal to have that discussion about risk with patients. But from the surgeon's perspective, you also have to understand the patient side of this, and especially the patient convenience side of this. And so when you talk about adding procedures, it's true that there's a great paper from John Kim, who's a plastic surgeon in Northwestern, who looked at inpatient plastic surgery data and inpatient surgery data actually, and showed that there's essentially a straight line linear relationship between time spent in the operating room and risk for clots. And so in that sense, there is a certain amount of surgery that maybe is too much. And I'm always talking about patients about what surgeries do I think we can safely combine from a time spent in the operating room perspective, and what surgeries would I rather split up. But to be fair, we're talking about surgery it carries a very low risk, right? We know from aggregate population data that the overall risk in even combined procedures might be 0.2%. And so if your risk is going to double, or even there's data in that Winnicor paper that say your risk goes up by a factor of 5, right? But the factor of 5 was something like 0.04% to 0.2%. And yes, that's a factor of 5-fold increase. It's an absolute risk increase of something like 0.16%. So balancing with the patient to say, listen, would you rather split your surgeries up into 2 surgeries, 2 recoveries, and accept a lower risk for clots? Or would you rather accept a higher 0.16% risk at 30 days in order to have everything condensed into a single surgery? So those are the things that I am balancing with people all of the time, talking about your risk, your goals. I have definitely turned people away because I said either your goals or your risk level exceeds what I'm willing to do. But for a lot of people, I'm having the conversation about, is there a balance that we can come to that balances my risk tolerance and your risk tolerance, right, with the benefit that we're producing? All great questions.
Well, I think one of the things that comes out of all of this discussion that you just mentioned is one of the most important things that I'm working on now as an initiative, and that is, and it's on my website, I'm trying to encourage people to huddle with their families and do their baseline risk, take it to their doctors for validation, and put it in their medical record. So let's say now somebody comes to you, they should ideally, if because people don't ask about family history, or they sort of ignore it and so on and so forth, or sometimes maybe they hide it because they don't want you to say no to them. But in general, if you have that baseline information already, then you can plan much more appropriately. And that's what I hear you saying too, that when you first see these people, you try to get that information and get it in the record. So
yeah, I'm asking about that with patients. Absolutely.
yes. So Chris, it's a great pleasure to have you do this. I'll be very excited to see the response. And I'll say this in conclusion. I can't wait to see what your next paper and your next conclusion is, because you're a very stimulating and educated young man. And we all look forward to hearing you going forward. You're a great force in plastic surgery. And thank you very much.
I appreciate you having me on.
Yes. And I thank the audience for listening to this, and we'll be happy to entertain any comments, especially contrary, because we're always trying to improve things, and we're always trying to, again, save lives. So have a great day, Chris. Thank you very much.
Thank you.